Hello and welcome to this episode of 10 Conversations for 10 Years, a series of dialogues that Pedro and I are having with a range of healthcare leaders across the globe to think about the future of the field of healthcare improvement. And Pedro, welcome to this episode.
Thanks, Amar, and it's so good to be together again, and it's so good to have you here with us, Kedar, for a conversation. It's been a great journey actually of learning, reflecting back, and looking forward. So we're looking forward actually to having a chat with you over the next half hour, 45 minutes. So Amar, do you want to get us started?
Yeah, just as an introduction, Kedar, welcome and thank you for joining us today. Kedar, for those that don't know, has a very distinguished history in the field of healthcare improvement, physician, improver, leader, now CEO and president of the Institute for Healthcare Improvement, which is a non-profit which really leads the field in thinking about how to apply improvement science to improve health and healthcare across the globe. Thank you so much for joining us today for this conversation, Kedar.
Well, thank you both for having me on your program, and it's really great to be with two good friends and colleagues, and also to mark this occasion with all of your colleagues at the East London Foundation Trust. You have done incredible things over the last 10 years and well beyond that time, and I know you'll continue to build on that legacy and success into your future. So thank you for your partnership and your work leading the field. So thank you.
Thanks, Kedar. I mean, part of the reason we're doing this series is to reflect back and then look forward. And I wonder if we might start there and offer your chance to reflect on what you've seen evolve in the field of healthcare improvement. You've been involved in this field for many, many years now, culminating in your role now leading the IHI. What have you seen evolve in the way that we practice improvement?
Yeah, you're right. I've been involved in this field for a long time. And I would say, I mean, obviously the field is much older than my involvement in the field. But I was reflecting the other day that I met Don Berwick, who I know you've had on this program before, and my predecessor and the founder of IHI 25 years ago. And I met him in the context of my early career was spent in global public health. I was doing work in a tuberculosis treatment program in Peru, actually. And Don was visiting because we were struggling with system improvement changes and challenges in Lima in that program. And I met Don for the first time, again, many, many, many years ago. And I remember now some of the way that Don was asking questions about aims and measures and changes and what iterative cycles of improvement might look like as we were trying to scale this drug-resistant tuberculosis treatment program up. All questions that I thought sounded so odd at the time. And now, as it turns out, I spend my days more or less asking those same questions of everyone I interact with in the world. So just a personal note on that history. But yeah, the field of improvement has changed over that 25-year period and in the years prior to that. I think of kind of modern quality improvement in healthcare, at least having at least a 100-year history. And I think it's kind of graduated through a series of successive eras. Ernest Codman probably began the modern quality movement in some ways. Ernest Codman, surgeon and healthcare leader in the United States in the early 1920s, really led the development of standards for what defined a healthcare facility as a hospital or a clinic. And in fact, the document that was written at the time was called the minimum standard. And it was literally a document that codified what it meant to be a hospital. It became the basis of the Joint Commission here in the United States and what became kind of the era of quality assurance in healthcare that followed. But for essentially 50 years, that was how we understood quality. We understood it as essentially adhering to a definition of what a minimum standard for a hospital or a clinic should look like. About two things happened mid 20th century. One was the evolution of the thinking that Walter Shewhart and Edward Deming were doing to codify management strategies that would result in iterative improvement in industry. And in the 1980s, those ideas were brought by people like Paul Batalden and Don Berwick over to healthcare. At the same time as those ideas were being brought over to healthcare by Don and Paul and others, a different revolution was taking place in healthcare, and that was the development of evidence-based medicine. And it surprises me even now, Amar and Pedro, that evidence-based medicine as a phenomenon really only has a 40-year pedigree. I think of it as being eternal and forever, but in truth, the phrase evidence-based medicine was only coined in 1987, and it essentially co-evolved with what we think of as modern quality improvement in healthcare. It occurred at almost exactly the same time as the demonstration project was taking place here in the United States, that Don and Bland Gottfried were leading, translating Deming's ideas into healthcare. And that became the basis of kind of iterative cycles of change that we now commonly use in our practice of quality improvement. And then the third era I think of as even more recent than that, in the last 20 years or so. That's the era of collaborative improvement, where we've gotten larger and larger teams of people together, working together to solve big problems that we share a common understanding of and a common aim to conquer. And each of these successive eras builds on each other. The standardization of Ernest Codman has not been left behind. We still have the Joint Commission and DNV and quality assurance activities, that look and feel much the same as they have for many decades now. We have, of course, evidence-based medicine and quality improvement that's come into the picture, and we also have collaborative improvement. Every era has built upon the previous era's both successes and also some of its weaknesses. But I think the next era will be interesting as we think about moving from what has largely been an analog era of quality to what I imagine will be a digital era of quality in the future. So I'm sure we'll get into some of that in a minute. But as I think about how the field has evolved, it's really in these ways over the last 100 years or so.
In a global organization like ours, Kedar, I've been with you over the last year in Brazil, in Copenhagen, in Boston. I had a phone call with people in the Middle East last week, and they had just been with you. So you get to see a lot of things around the globe, and it's quite exciting. So you gave us a really lovely summary of some of the headlines of the last few decades of improvement. But we're here, right? The job of people like Amar and yourself and many others leading improvement out there is to shape both the present and the future of improvement. So as you look at the now, and we take a pause there before we look forward, and as you get to see many things across the globe, in terms of the use of improvement science used to create better outcomes, better experiences for and with patients and communities, and better health. What really excites you at this point in time?
Yeah, it's a great question. In some ways, the thing that excites me the most is when our teams, Pedro, you know this very well because you and I have been together at IHI for, I don't know, quite some time now, more than a decade. But every Monday at IHI, there's a staff meeting. And it's been true at least as long as I've been at IHI. And during that staff meeting, we lead the staff meeting off with usually a project description of some kind, some team from somewhere on the planet. And Pedro, you're very right that we now operate the organization in 24 countries around the world. There's literally not a place on the planet that isn't awake working on IHI business at some point during a work day. And what's exciting about the staff meeting is it begins with a team from the organization coming and presenting what they're doing. Yesterday's staff meeting, we're recording this on a Tuesday, so yesterday's staff meeting had a description of a multi-country program to prevent pain in children. And I mean, and there was results. There were both learning results, there were experience results, there were process level of improvements, and actually a very surprising improvement in outcome, a 20 percentage point improvement in the experience of children who were having needle sticks and the pain that they experience as a result. I mean, that's the kind of thing that, excites me anytime I listen to it. If I hear a successfully operated improvement initiative of almost any kind, I can pretty much get excited about what they're doing. So that kind of better result is what I am very stimulated by. That particular project was operating across many countries, so that also excites me. The notion that you can take an improvement concept like reducing pain in children, and it doesn't just have to operate at a single institution or a single team level, but it actually has the ability to be resonant across many countries. The experience of children having pain is not uniquely occurring in a single institution in one location. It's a global problem. It's a global issue. It has evidence that can solve for it, and that's my third kind of thing that excites me. When we see something that we know actually reach people that could benefit from it, which I think is the promise of improvement, that is exciting to me. So we've known for a long time that exactly how to prevent these kids from experiencing, from any kid getting having pain when they had a needle stick. We've known for a long time how to do that, but we don't do it, bizarrely. And in some ways that might seem kind of perverse, as if we are intentionally inflicting pain upon children, which is clearly not what we're trying to do as healthcare providers. But we simply don't apply the evidence, as many of you and many of your listeners will know. We just don't do what we know very often, or even most often in some instances. In this case, prior to this effort, the rates of application of some of the most evidence-based practices was 1 in 5. So the vast majority of times, only 20% of the time, kids were getting the things that we know can prevent them from experiencing pain. And yet we don't do it very often. I was particularly struck by that presentation because literally 3 days ago, I took my son to have a blood draw at the hospital, and I was very impressed. And he was absolutely terrified, and as kids are of needles, as you both know. And I was positively impressed with the fact that they had a numbing agent on hand to allay his fears and improve his experience and not have him suffer through a routine blood draw, which was pretty exciting to see. So that kind of thing is always what excites me, better results. And there's many case examples and stories of that happening every week, really, at IHI from across the world.
Well, I think firstly, what you've described as exciting you, Kedar, is probably very similar to what excites all improvers, no matter where they work in the world. I think a lot of it is the human connection to the impact that our work can have and being able to relate to that in different ways. I think the gap between where we see ourselves or where a team sees itself and what they want to be able to do and helping them bridge that gap is a really fulfilling role to play in enabling people to achieve things they never could. I think the evidence-based question is a really interesting one because the field that I'm largely working in, there's very little evidence-based sometimes for the problems we're trying to solve. You and I were talking about this challenge we've had about reliable observations in mental health inpatient units, and actually the evidence is slim about how you really use observations in a therapeutically minded way. And it's been a challenge we've grappled with for the last 16 months here, and it's been largely innovation. It's been largely creating new ideas. And for me, that's where a lot of my joy comes, is in seeing people discover new ways to think about how they can tackle these sorts of big challenges and gaps. And yet I think there's still things that we're not getting right about improvement. I think about the phases of improvement you've described, and moving, I think, from collaborative improvement to co-produced improvement is perhaps going to be the next phase for us. We still see a lot of variation in how well we co-produce improvement with the people who use our services. Thinking about where we've devoted our attention in terms of quality improvement and the domains of quality, it's not equitable, the types of things we've been focusing on. So what do you think the next phase, the next set of years in quality improvement might hold for us? Where should we as improvers be thinking about applying our efforts?
Well, I think you're right. So I have actually, when you when you're asking this question, I think you're right about co-production. I do believe that the next era will have co-production will be a big part of what we will be doing in the future. I also think the next era will be, as I said earlier, digitally enabled. I think that we have largely relied on, in every one of the previous eras of quality improvement or healthcare improvement, we have relied largely on analog strategies for improving. And I mean that not just literally in terms of the data flow that we have, but also in terms of our ability to harvest ideas, to share in the ability to develop new ideas or new thinking, the democratization of knowledge, the democratization of production, not just knowledge, but also production, to get to your point about co-production. All of that has been essentially mediated through us as professionals, through the environments in which we work, the hospitals, the buildings, literally the structural phenomenon in which we work. And I think a future for healthcare, a future for health creation more broadly is not going to be moored to institutional walls. In some cases, it will be when you need it. But for the most part, it won't be. It won't be determined only or solely by professionals, but it'll be largely determined by choices that you're making in everyday life, and largely by the people around you that have nothing to do with formal degrees in healthcare at all. And it'll be shaped by your interactions, not just with those individuals, but also mediated through technologies like the one we're on right now. So that's why I think the sort of future of health creation, and if healthcare improvement wants to be relevant to health, then we have to ask, what is health creation going to look like in the future? And health creation in the future, I think, generally looks like something quite different than what we have today in terms of healthcare. And so that's why I believe that we're going to have a much more digitally enabled, technology-enabled environment that will involve a significant amount of co-production that will allow us to deepen results. I think we'll have a different workforce that's guiding this. I think, I'm part of something here in the U.S. that's called higher education as a strategic asset. It's actually not about healthcare. It's about how we plan to educate the future workforce. And it's a very interesting problem, actually, here. It's a presidential commission here in the U.S. that's focused on this question. And I'm thinking about it because we had our conversation about it yesterday. And it's very interesting because at the moment we suffer from essentially a uniquely new problem. And that is that previous generations, including our parents immediately before us, largely knew what the workplace was going to look like for their children as they moved into that future. And so they could prepare all of us for that future. But as I look to my kids and wonder about what work will look like for them, I don't really know what it's going to look like. And therefore, our ability to prepare our children for that future is very, very challenging. We don't actually know what skills and knowledge and technical competencies they should have as they approach those future work environments. And I think we're going to need to build a fundamentally different workforce that has both different technical skills, but I think more importantly, actually has what's being described as the 4 C's of the 4 new competencies for leading in the future. And the 4 C's are, critical thinking, communication, creativity, and collaboration. Those are the skills that we're going to need to equip our workforce with in the future. And I think that's going to largely shape what improvement looks like in the future. It's interesting because I think improvement is fundamentally already connected to those ideas. If I think about those 4 things, critical thinking, collaboration, communication, creativity, the foundations of a PDSA cycle or modern quality improvement really require at least some reasonable amount of aptitude in those 4 areas. So I think in some ways, if you are practicing improvement today, you are likely preparing yourself and those around you and your teams for what the future of work is going to look like, which is kind of an interesting way of thinking about improvement right now. And I think a little bit different than we've generally thought of it as. We've thought of it primarily as a technical solution to a series of problems like applying evidence to every environment. But I actually think that fundamentally, the skill base of the future is going to be about how we manage change and how we continuously learn, because your profession today will not be your profession 10 years from now. And healthcare and improvement as a methodology allows us to be adaptable. And even as adults, which we tend not to be adaptable once we've left our formal schooling period. So I think if you're in improvement today in your world, wherever you are, whether you're in healthcare and education and housing or wherever, if you're focused on the kind of skill base that improvement teaches you, you're essentially preparing yourself and generations that will come for what the workforce will look like in the future.
It's really fascinating. I know that there are some higher education facilities now really moving away from subjects and thinking about sort of these sort of competencies and capabilities. I just wonder whether we should be thinking about this way of thinking and approaching life being embedded in school age children. Do you see that happening anywhere in the world?
I want to say, so we're looking right now at innovative models for this. This is part of what this commission is looking at the moment, is innovative models for approaching. And there are, charter schools and innovation programs that are kind of looking at the development of a social skill base in addition to a technical skill base. So already, I think in some way, we are starting to value those skills, but a formal kind of approach to developing those skills so far we have not yet encountered a school that's sort of founding its curriculum or basing its curriculum after these kind of change concepts. That said, I think that improvement, as I said earlier, I think improvement kind of embodies these change concepts. And so, in some ways, if you are a certified improvement advisor, you've been studying how to collaborate, how to be creative, how to think critically about problems that you're facing, and how to communicate about them effectively for a long time. And you've been managing change and continuous learning as a foundational skill set that is, in addition to statistical process control and run chart rules and data over time and psychology questions, et cetera. But we have been studying these questions for and learning about these skills for a long time in improvement.
I just want to remind people on this podcast or this conversation about those four. I think they should be part of a blueprint for all of us actually into the future: collaboration, creativity, communication, and critical thinking. And part of the opportunity, Amar, that I see in the work that you're leading nationally in your role with NHS Impact and in the opportunity that we have with the integrated care systems is to go beyond a one-dimensional approach to quality improvement, which I think has tended perhaps to be overly technified, and maybe frame this as an opportunity for that collaborative space with schools and justice and police and fire services and so on to work on population health using those 4Cs in the background and leveraging improvement, the ability to understand your system, the ability to have aims together, the ability to test changes, and the ability to measure what you do over time as a kind of generational opportunity to transition maybe to a different dynamic. And Kedar, maybe that's my last question for you is, have you seen spaces in any of your travels recently, I would say over the last 5 years, where that kind of collaboration, which breaks the walls of a single system or institution, let's say healthcare, or let's say a hospital, and welcome people into a collaborative space to work for something that's much bigger than themselves in terms of things like population health and so on, that leverage the essence of improvement, but perhaps in a slightly less technified way, but more of an intuitive approach to, again, understanding systems, measuring changes, having aims together, and so on?
I don't know that I've seen. Look, I think there are many ways in which we've started to try to work across sectors in different parts of the world. There's, I think, useful intersections between housing and healthcare, and between employment and healthcare, between schools, jails, and prisons, as you mentioned. I know you've had on the program Jason Leach in Scotland, who's been Scotland's pioneering, I think, in many ways in some of these dimensions. They've kind of been a pace setter for the rest of the world. But I still think we tend to erect verticals and silos, as a way of managing social systems. I think we still largely treat the budget and the management challenge of public education in one silo and housing in another silo. So while there are occasional intersection points that are breaking that mold, we've tended to do that, frankly, in quality, right? We've created a vertical silo around safety, a silo around quality, a silo around equity, a silo around value and population health. I think it's a very unfortunately a somewhat patterned human response to management problem, which is to erect a silo, put a manager in charge of it, sign a budget and let them go. It's just a way that we've done it historically without seeing. And then we have that creates a problem of, wrong pockets, this sort of problem of where does the value accumulate when you invest in improving one sector, the actual benefit might be to another sector, all these kind of things. It's all because it's all coming, by the way, from the same public treasury, the same general impact on the whole population. And you can understand those impacts, but we've erected essentially a management strategy that has separated the parts and therefore sub-optimized them. A Russell Acuff lesson from years and years and years ago. We've kind of divided and conquered, and literally divided and not conquered in many ways in this particular case. So anyway, I would say that there aren't as many of these scaled experiments at whole system transformation, and I'm not so confident that we will have them unless we more fundamentally change the way that we approach our understanding of of these phenomenon. And I think we can begin in quality. We don't need to have the silos between safety, equity, value, population health, and quality is a good example where we can start at home in our arena of quality and quality improvement, where we can begin to unravel those silos, break them down, see that they're all part of the same picture, and build systems that can help our staff achieve improvements in all of those areas simultaneously, rather than assigning them to different verticals and having them managed separately.
Thanks, Kedar. As we get to the end of our time together, I just wondered if I could ask you for one last bit of advice for those who are listening. We're hoping to reach the global community of improvers in health and care through this sort of series of conversations. Is there one thing that you really think you'd suggest to us all as improvers that we should be thinking about, learning about, paying attention to in our daily practice of improvement? What would that one bit of advice be for us?
That's a tough one to answer, Amar, easily. I would just say that, look, I think the skills that you are building, again, as the world encounters a period of what I imagine will be very significant change over the next decade or two to come. Part of what I think improvement is all about is learning and adaptation. Fundamentally, at its core, the essence of improvement is about being able to change successfully and to be able to adapt to new forms of knowledge and new forms of understanding. And so you're honing and refining of those skill sets of how to accommodate and understand change, and then how to adapt to it or affect it insofar as you need to. That's going to be the most valuable and important asset in your future life. This notion of lifelong learning is so foundational to improvers everywhere, and I believe it is the foundational skill for the future of our societies. So maybe I'll leave you with that idea.
Well, there you go. On that very profound note, thank you, Kedar. A great conversation. I'll just say, Kedar, that speaking on behalf of all of our people at East London Foundation Trust, it's been a real privilege to partner with IHI in this long-term journey, and I'm not sure we could have got to where we have without your guidance and support of the whole IHI family. So a big thank you from us all, and thanks for joining Pedro and I on this conversation today.
I'm very happy to be here. And let me just repeat or reciprocate your gratitude to us. I mean, the IHI is nothing without its partners, and is in some ways you have taught us as much as we've had a chance to be a part of your journey. So, I expect that to continue. By the way, so no pressure, but I imagine that you're going to be shaping the path for for many institutions in the future, both in the UK and elsewhere around the world. So thank you so much for what you've done already and what you will do in the future.
That's really kind. Thanks, Kedar. And thank you, everyone, for joining us on this episode. It's been a privilege to have you with us on this journey, and see you on the next episode coming soon. Thanks, everyone.